Welcome, everyone. I think you're going to find this an excellent meeting, very topical. And one of the aspects of this is we're going to have a lot of people registered and people are still coming in. I ask for you to understand that you'll be muted while the speakers are presenting. And during the Q&A, you'll be able to unmute yourself. Okay, you also can put whatever you like into the chat, what you're interested in. And for the Q&A, you can raise your hand either just on the screen, or you can go into reactions and put your hand up that you have something that you want to say. Let me begin by saying thank you to Patrick Glasso or Sign and for giving us his expertise, and to Sarah, who did a lot of the organizing and getting this done, Sarah Smith, who's with us at Mind Freedom, and also Susan Fitzmaurice, who is the leader of I Love You, Lead On. Just quickly, we do these meetings every month, the first Wednesday, and we try to have topical material and for people to come together as part of a joint community that's cross disabilities. Hopefully you'll get a lot out of this. And the speakers we have today are quite impressive in their backgrounds. We're gonna go through, I'll give you the bios, the short bios, I'll read them. The first presenter will be Bob Whittaker, who, I don't know, I think I met Bob when his first book came out, Mad in America, when he was still learning what the system was about, but did a great book for, which eventually, I guess, was used as a title for Mad in America. And he's done great work. And I will, let me introduce him by his written. Robert Whittaker published his seminal book, Mad in America, Bad Science, Bad Medicine, and the Enduring Mistreatment of the Mentally Ill in 2001. With that book, he began more than 2 decades of investigation and critique of the modern mental health system. Whittaker has continued to write other books challenging mental health services and treatment of those who use them. Whittaker also runs madinamerica.com, a platform for critical examination of mental health and the mental health industry, where a broad selection of critics and psychiatric survivors write. Welcome, Bob.
Thanks, Ron. It's a real pleasure to be here, and thanks for this invitation. You know, I owe a lot to Mind Freedom, going way back for 20 years, I just want to say. And you mentioned, Ron, about learning. Well, I'm still learning, but I first went to school on Mind Freedom many years ago. So what I thought I would do really quickly, and again, I think this is such an important discussion, so thank you for inviting me, is just go over a little bit the history of sort of suicide prevention efforts over the past 20 years. And these are suicide prevention efforts that have really taken place, you know, at a larger public health level and within a medical model, within the current paradigm of care, which, you know, we've had since DSM-3, which sees the problems as inside the biology of a person's head and so forth. Well, you see that at a national level, suicide prevention efforts really begin. The first organization to take hold, the American Foundation for Suicide Prevention, was started in 1987. Before that, there was no national organization and there was no national policy directed towards suicide prevention. And they declared themselves the first nationwide organization dedicated to understanding and preventing suicide through research, education, and advocacy. Now, very quickly, they formed a scientific advisory board, and on this board were mood experts, academic psychiatrists, who specialized in mood disorders and who had very close ties to the pharmaceutical industry. They worked for them as consultants. They did their research, advisors, et cetera. And by the way, 1987 is an interesting year because that's the year Prozac comes to market. And very quickly, what happens with the academic psychiatrists who have these close ties to pharmaceutical companies, that group, those two groups, academic psychiatry and the pharmaceutical industry, really take over this foundation. And pretty soon, like one of the leading experts is a man named David Schaefer. He was chair of child psychiatry at Columbia University, and he eventually becomes president of this foundation. And he launches, for example, the Teen Screen Initiative, which seeks to screen teens and adolescents for suicide and depression. He becomes president in 2000. After that, his colleague at Columbia University, J. John Mann, is the president. After that is the famous Charles Nemiroff. He was sort of the poster boy for corruption in academic psychiatry. Then we have Jerry Rosenbaum. The point is it moved, there was sort of a family impetus for starting that foundation, but very quickly it was taken over by academic psychiatrists who work for pharma companies to serve as their experts and do their trials, and et cetera. Now the pharma companies began funding the foundation, this American Foundation for Suicide Prevention, in the 1990s. They began holding fundraisers, gave them donations. They became members of the board. Pharma representatives became members of the board. And the message that came out of that foundation was you need to screen for depression and suicide, and the preferred treatment is antidepressants. So what I'm saying is this understandable effort to sort of reduce suicide, which you can see is a good thing, but it gets tied in with the marketing of drugs and the expansion of the psychiatric enterprise. And you also see that with these two groups together in the 90s, they have a lot of lobbying presence. And you see, for example, in 1998, US Surgeon General says he calls suicide a national, a public health problem, and that we need to, in 1997, Congress passes a resolution declaring suicide a national problem and suicide prevention a national priority. And the Health and Human Services forms a national strategy for suicide prevention. Now, interestingly, at that time when we're declaring it a national priority, the suicide rate at a national level is about 10 per 100,000, and that was close to a 50-year low. So even though what you see here is, even though suicide by the sort of usual standards had reached to a low level, we were declaring it a national priority. Fine, but it's because, in fact, it was also seen as a way to market a drug, to market this sort of form of care. So, and then you eventually get out of this a national plan to prevent suicide, et cetera. It becomes sort of a governmental initiative as well. So that happens in 2000, and the suicide rate was 10.4 per 100,000 at that time. And over the next 20 years, it rose steadily. It rose year by year as we implemented these suicide prevention and educational programs. And it's now like 35% higher than it was in 2000. So that's the sort of correlational statistics of when we begin focusing on this, and we see the problem within a medical model. This is the key, where you see the problem is a person has something wrong with themselves. They have the illness of depression, and they need to get into treatment. That's really the paradigm that is being pushed. Now, there's been research looking at this model of suicide prevention, and it's all negative. So I'll just go over this real quickly, some research findings. First, in an Australian study, and this was basically from 2010 forward, these findings, a study by Australian researchers of 100 countries where national mental health policies were introduced. And when they introduced these things, and they did this study, they said, well, let's look at suicide rates as a marker of the effectiveness of the introduction of these mental health policies at a national level. And here's what they found. Adoption of mental health legislation across these countries was associated with an 11% increase in suicide. Adoption of a national mental health policy was associated with an 8.3% increase in suicide. And adoption of a therapeutic drugs policy to improve access to psychiatric drugs was associated with a 7% increase in suicide. Now, all these national programs are coming within a paradigm of care that, as I'm saying, has a disease model of care. Next, there was a team of UK researchers of 76 countries, and they found that higher rates of suicides in countries with greater, they found higher rates of suicides in countries with greater provision of mental health services, including the number of psychiatric beds, psychiatrists, and psychiatric nurses, and the availability of training mental health programs for primary care professionals. So as societies increase their mental health focus and number of professionals and capacity to provide services, unfortunately, you saw this that was associated with an increase in suicide. Then in 2013, in a study by Danish researchers of 191 countries, it's basically all the countries in the United Nations, they concluded that countries with better psychiatric services experience higher suicide rates. Quote, both the number of mental health beds and number of psychiatrists per 100,000 population were significantly associated with higher national suicide rates. So that's the first body of research. When you look at countries that adopt this paradigm of care and adopt these sort of suicide prevention efforts based on that model of care, you see, and it's associated with an increase in suicides, okay? Then there's been studies about suicide rates in patients who get psychiatric treatments, okay? I'll mention two studies. There was a Danish study, and they found that the risk of suicide rises with each increase in level of treatment. It was 5.8 times higher for people receiving psychiatric medication but no care, 8.2 times higher for people having outpatient contact with a mental health professional, 28 times higher for people having contact with a psychiatric emergency room, and 44 times higher for people admitted to a psychiatric hospital. Now, of course, people accessing services may have more risk factors. However, these increased risks were seen as much greater than you would see just by the baseline severity of problems. And here's what they concluded. It is entirely plausible that the stigma and trauma inherent in, particularly involuntary psychiatric treatment, in already vulnerable individuals contribute to some suicides. We believe it is likely that a proportion of people who suicide during or after an admission to hospital do so because of factors inherent in that hospitalization. Perhaps some aspects of even outpatient psychiatric contact are suicidogenic. I mention this because as we get into the hotlines, one of the questions is, sometimes there's tracing of calls and they send people to the home, which leads to forced treatment. And anyway, this is evidence that that can be quite traumatic, increase the risk of suicide. Now, we also saw an increase in suicides among Army veterans. So the Veterans Administration in the United States conducted an exhaustive survey of 55 million records of veterans and looked at suicide rates for veterans from 2001 to 2014. And here's what they found. Those with a mental health substance abuse diagnosis who got mental health treatment were 50% more likely to die by suicide than those who had the same diagnosis but did not access mental health treatment. In other words, they didn't go in to get treatment for that diagnosis. Those without a diagnosis who got mental health treatment, in other words, they got prescribed an antidepressant or something, also died by suicide at a higher rate than those without a diagnosis who did not get such treatment. And by the way, one thing, often, of course, one of the treatments, and this was in the suicide prevention efforts, was with an antidepressant. And if you really look at the data, if you can get into the actual data of RCTs, it shows an increase in suicide and suicide attempts by those treated with the antidepressant compared to placebo. You also see in primary care, when people come in with a milder form of complaint, those who get placed on an antidepressant have a much higher rate of suicide than those who do not. So this is just a very quick introduction to what the research has shown over the last 20 years as the US and other countries have launched national health programs, mental health programs to reduce suicide, but they're doing so within this framework of understanding that it's sort of an illness and the individual needs to be treated by mental health professionals. The data, I think, is pretty clear. It hasn't worked. And in essence, you see increased suicide rates associated with that type of intervention. And really quickly, we did an article on this called Suicide in the Age of Prozac, and all that research is there. So that's it for me. I just wanted to provide a little bit of framework for these conventional interventions, sort of done from top down. We would talk about peer-led interventions Karin was talking about, but these are really top-down interventions, often by, that come from psychiatrists, that come from policymakers at governments, and I'm pretty sure often not with much input from people with lived experience. And so I think what we've seen as a failure is that model of suicide prevention and that model of intervention. So thanks.
One of the questions in the chat is, are there any specific drugs that have been pinpointed as being, more likely the cause of suicide in these cases?
Well, the drugs that have been most studied for suicide, risk have been the SSRI antidepressants and some of the SNRI depressants. And at least with the SSRI antidepressants, that was Prozac, Paxil, those class of drugs. Once researchers were able to get to the raw data in the RCTs, they were able to find that there was an increased risk of suicide, by the way, for all ages. Initially, the FDA said it was just for people 25 and under, but when they got access to the greater wealth of data, they showed that there was increased risk of suicide for even people above 25 years of age. So it is the SSRIs that seem to have been most studied and have this increased risk.
Thank you, Bob. There's going to be a lot of time for questions afterwards, but let's let the speakers finish their presentation and then we'll get back to the questions. The next speaker is Karin Jervert, who is an artist, author, and activist. She identifies as a survivor of psychiatry. Her work explores empowerment, the normalization of suffering, and the power of creative expression to transform trauma, both individual and collective. Javert is currently the arts editor at Mad in America and led Mad in America's Suicide Hotline Transparency Project in collaboration with Maggie Leppert and others. This project aimed to provide people in suicidal distress with the resources and information they need to make an informed choice about hotlines to call, particularly since call tracing for some can lead to traumatizing or even lethal interventions. It included 3 interviews with lines that do not trace or intervene without consent, a community poll, and a directory of lines with their policy information publicly available on Mad in America website. Thank you, Karin. Karin.
Karin, yep, car in the garage. That's the best way to remember it. Listening to Bob, just honestly, Bob, this is why I work with you. You have been laying out these truths and this data and bringing it into the light for so long. And the thing is trying
to figure out why she's unmuted. I mean, why she's muted.
Am I muted? I don't think so.
I can hear you.
Maybe, well, you'll figure it out if it's only you. Yeah, it looks like other people can hear me, so we're okay. What I was saying was the data that Bob sort of lays out in this very clear scientific journalistic language. Within that, for me, is my story. And listening to the data he's sort of laying out there, I'm, just sort of washed over with my psychiatric history and the horrific abuse and treatment that I received that did basically, I had 5 years of chronic suicidality as the side effect of a medication. And that was just a part of my journey. I was involuntarily hospitalized 4 times. I was labeled bipolar at 21. At around 39, 40, I started to come into the peer movement, the psych survivor movement, and been on a different healing journey ever since. So I just am, honored to work with you, Bob. That's all I'm saying. So, so I came to talk a little bit about the Suicide Hotline Transparency Project. So I started thinking about this immediately when I started working for Mad in America about a year and a half ago now, I'm not sure. But it was a campaign that I wanted to do early on because I had had my own experiences with literally fleeing my home to escape psychiatric intervention from police, or well, police intervention and psychiatric involuntary treatment. So, and I was very aware as well of communities that are disproportionately affected by these kind of horrifically violent police interventions. And as I went through the project, I was able to connect with some wonderful organizations who are doing work specifically around suicide hotlines and crisis lines that are serving these populations, and just doing the work in a way like, you have conversations with people and they're like, it can't work like that. And you're like, no, it can, and it does. People are doing this work right now. They're serving people in a way that respects their dignity, their sovereignty over themselves, and reduces the harm of these kinds of psychiatric, these kinds of police and psychiatric interventions, non-voluntary. So what we did was we had a poll, a community poll, where we had about 50 people so far respond. It's a breadth of users that responded. The full interpretation of the results is being worked out by my partner in this project, Maggie Leppert, who's going to be publishing an article soon with the poll results and sort of a general look at what we found. So, but a little kind of peak is really, that we ranked what the highest, most important concept of a line would be, or what was most important to users of a line. And it really did come through that confidentiality and anonymity and lack of police response was an extremely high concern of people, and these people calling this line. So the kinds of things that they reported as important to them are not the things that are implemented in this, psychiatric kind of care that Bob's talking about, this initiative that's starting in the early 90s, right? So, and the NSPL and what's being kind of adopted by the 988 stuff. So, I mean, it's hard to summarize everything that I learned from this project. And I want to shout out the interviews that we did, because these organizations are doing amazing justice work around this stuff. So please check out the Trans Lifeline. They have a advocacy effort right now called Cops Out of Crisis, being led by Yana Kalu. And they have that line that serves trans individuals, trans and non-binary individuals. So then we had an interview with Vanessa Green from Call the Black Line, which is serving Black folk. So this is like, these groups are just doing such important justice work, along with the Wildflower Alliance, who have a peer support line, who also, all three of them do not contact police and respect the sovereignty of the caller around consent. So I'm not sure, let's see, what else would be helpful to mention around this project. I would love for you all to check out the articles for more information, so I don't take up too much time, so that you can see the podcasts and the interviews and the project itself. We have a directory of lines that we're still building around the publicly available policies of lines that we did. We outreach to these lines, 3 rounds of emails trying to get sort of very clear answers to the consent question. And There's an ongoing call for art. We were going to do a show, but I'm going to extend this is to an ongoing sort of call, so that around compassionate gestures, since in suicidal care. So this is my thing. I'm an artist, really. Journalism is sort of something I'm learning as I go along with Bob, but you know, it's a language I'm learning. But art art and healing is my key focus at Mad in America. But this was a very important project for me personally, and I think was something that I could contribute to this effort that's being done by so many other organizations. Also, Project Let's as well is doing some wonderful work around this. So I think I'll stop there. Thank you for having me today. I really appreciate the time to talk about the project, and I hope you all check it out on Mad in America's website.
Thank you, Karin. Appreciate the work that you're doing, and thank you for presenting. Our next presenter is Rob Wipond, who is an investigative journalist and author of the upcoming book, Your Consent is Not Required: The Rise in Psychiatric Detentions, Forced Treatment, and Abusive Guardianships. I met Rob when he was interviewing me about my thoughts on forced treatment. So here's Rob.
Hey, thank you. I'm enjoying your gesturing there, Patrick. Thank you very much for being here with us tonight. Hi, everybody. I'm Rob Wipond. Yes, I've got I'm just going to do a sort of quick overview for those of you who maybe haven't read some of my articles, or not all of them, about these issues that we're talking about tonight. Specifically for me, it's around crisis lines that do call tracing and then send out police and or mobile crisis intervention teams against people's will, often, or under strong coercion. So yeah, I first heard about this myself about 25 years ago. It was really only the second article I'd ever done on mental health issues, and somebody told me that this had happened to them, and I was aghast and almost didn't believe it. Like, what? You're having a call with an anonymous crisis line and the police showed up? Like, how did that even happen? So I asked the local crisis line director about it, and she came down and she actually talked to the publisher and editor and said that she was very irate that we were going to publish this, because she told us that there was a voluntary media blackout around North America about publishing this, kind of like how media agree not to publish the location of a shelter for people suffering abuse, for example. This is, there's no law against it, but media don't do it. And she compared it to that. I had never verified if that was the case or not. I don't know. But it is important to note that certainly the presence of social media over the last 20 years has made it very obvious that this goes on, and it goes on a lot. And I think in large part, we can all thank social media, for contributing to our growing awareness of this phenomenon. So yeah, that's how I got involved. I started working on my book. I'll put a link to that here in the chat box if anyone's interested in it. When I started working on that book, I wanted to find out some statistics on how often does this really happen. So I started contacting the National Suicide Prevention Lifeline, because they have 180 call centers. And so I thought they would have the most comprehensive data to offer. And this is important. They did not want to give me the data. they even though they were sharing it at monthly meetings with their own member centers, which is why I thought, oh, great, this will be convenient. But no, they did not agree to give me the data. So they directed me to SAMHSA, the Substance Abuse Mental Health Services Administration. They didn't want to give me the data either. It took literally probably 18 months of heavy duty, like pushing and prodding, and they kept saying, oh, we have nothing, and then they'd ignore me, and went back and forth. And why I mention that is because it tells you how much they really don't want the public knowing this. Even though the information's out there, they really don't want it promoted. They don't want a lot of people to know. At least that's my interpretation of all of this. So And I'd later learn that, in fact, SAMHSA and the National Suicide Prevention Lifeline had begun internal discussions while I was asking these questions about their policy and practices, and I'll return to that in a minute. So they do have a policy. It's called the imminent risk policy. And if you are deemed to be at imminent risk as a caller, or this also works through texting and chatting, they may submit you to active rescue, is what they call it, which is to send out police or mobile crisis team. They make this assessment based on 3 factors, essentially. Do you have the desire to potentially kill yourself? Do you have the intent to do it? And do you have the ability or the means? I don't know anyone who might be calling a crisis line who would not have these criteria. So that's important. The error rates would seem to be very high. If you're calling a crisis line, you're obviously in a somewhat ambiguous state probably already, but you may have the desire, the intent, and the ability to do so. So yeah, there seem to be some accidents that happen in the sense that lots of people who did not think that they were actually intending to kill themselves at that time are getting caught up by police interventions. So how it's done, landlines, of course, are attached to an address. Basically, all mobile devices now have the capacity to reveal your personal information and your location when 911, or what's called a public safety answering point, pings that. And when you call 911, this happens fairly automatically now as a service to you, right, to help people who are calling 911. And that's relevant for what we're going to talk about in a little bit. So that's currently how it's done, is a crisis line will call 911 and say, we want this call traced. So I got the statistics eventually and discovered that on average, it's 1 to 3% of calls that get subjected to these kinds of sort of coercive or flat out involuntary tracing and interventions. And some are as high as 7%, 7 or 8% in certain centers, just do it more than others for no one really knows why. They're just, and in some case, because only a small percentage of callers are actually there expressing suicidal feelings, it's probably a much higher percent of those callers who are being subjected to these interventions. Publicly, it's always presented, it seems, by these call centers and by the representatives as life-saving intervention. But we have very few statistics to verify that. It really looks like a really small percentage of this percentage are actually in the act of killing themselves at that particular moment. Most of those people, if they're regretful, will call 911. You're not dialing an 8-9-digit number, to suddenly say, help me, usually. You're usually calling to talk. So it seems to be a very small percentage of people. But it's nevertheless always presented in public explanations as this is what we're doing. We're intervening in people who are literally in the death throes. So, all right, so what happens? These mobile crisis teams are a new trend. I just want to flag that they certainly, obviously, there's going to be less shootings that occur when you've got not a police intervention, but a mental health intervention, because often they aren't armed, or the police officer with them is more appropriately trained to de-escalate. So that's a good thing. But nevertheless, they often forcibly hospitalize at a very high rate as well. A New York study found about 80 to 90% of police interventions for wellness checks resulted in hospitalization, and about 50 to 60% for mobile crisis teams who were specifically trained not to incarcerate people. So what's that experience like? Well, as a lot of you probably know, it can be really frightening. You have a profound sense of betrayal. Shootings have occurred directly linked to calls to the National Suicide Prevention Lifeline. People get locked up in psychiatric hospitals. That can be very traumatizing. They can be forcibly treated. As Bob mentioned earlier, suicidality increases a lot after you've been hospitalized, even voluntarily hospitalized. So we can only assume the worst about the long-term impacts on people's lives of this phenomenon. So a later Freedom of Information request that I did revealed that they know this. that the National Suicide Prevention Lifeline's own lived experience committee have been highlighting these concerns and worries, especially how they impact vulnerable or oppressed groups in communities, and have been flagging that to the leadership for some time. And certainly over the past 2 years was where I got that information. And you can get this on my website or on the Mad in America website. I'll put in some links in a minute. So since that time now, there's been a massive campaign to get a new 988 number instituted nationally. It's a quick call for crisis mental health stuff. And it has been awarded to the same people that manage the National Suicide Prevention Lifeline. So undoubtedly, this number it's going to roll out in July, supposedly, and it will undoubtedly increase the number of calls, which presumably will also likely increase the number of people who are going to be subjected to call tracing and forced interventions. And they're also campaigning, the organizers or the people that run the 988 number are actively campaigning to get a default embedded geolocation tracking right in, so that if you call 988, it'll be like calling 911. Your geolocation and some of your personal information will be automatically exposed, and then they'll access it directly if they need to. That's what they're campaigning to get that control. They do not have it yet, let me clarify. That's part of just what they're trying to get, and there's discussions underway right now. And that gets you down to about 3 meters on a vertical horizontal axis where they can locate you. So the Federal Communications Commission has been holding hearings on 988 and issuing reports. Up till now, they've seemed relatively neutral, but a recent forum last week, which our next speaker can talk more about because she spoke at it, to me, I was struck by how polarized the dialogue around this had now become. So SAMHSA, the FCC, and pro-intervention mental health organizations continuing to just hammer away that this is life-saving, not talking at all about any of the problems. And as California statistics showed, again, a high percentage of people that call the crisis line are people of color, children, and people under the age of 25. 2/3 are women, and so the survivors, consumers, people trying to represent them and representing critical mental health professionals at the meetings highlighted some of the risks that I've just been talking about, and the next speaker can talk more about that. So I want to just talk about a few safeguards. Lastly, I did get floated at that meeting, and that I thought were all good suggestions. One is don't trace at all. Really, do we need to do this? Save 911 for those kinds of emergencies. Make this a confidential, anonymous helpline. Or you could use less precise geolocating so that people can be directed to a local call center, but without being exposed exactly where they are. Transparent disclosure would be enormously important. Put it in the marketing materials, disclose it when people call or contact, tell them straight up, this could happen and here's when and how. Fines or removal from the 988 network for improper storage or use of people's personal data, because this is going to be data that they're accumulating over time. And finally, formal reviews of call tracing practices with accountability mechanisms. We have none of that now. We don't know what's going on, who's doing it better than others, why, how, anything like that. So we need a lot of studies. So I'll wrap up there. Hope I didn't take up too much time. Looking forward to the discussion and questions afterwards. Thanks so much.
Thank you, Rob. It's really good to have the facts. Our next speaker, who was very gracious enough to change her schedule when we invited her 2 days, I think, before she could commit. And let me, I don't think I've seen Keris. I haven't seen you in maybe 15 years, but let me read your background. Keris Myrick is a boundary-spanning, bridge-building mental health advocate who breaks down barriers with curiosity and creativity to disrupt the mental health system status quo to promote autonomy and flourishing where people live, work, and play. With over 20 years in the mental health field, Myrick fights to advance lived experience leadership, non-co-opted peer workforce, and dismantle disparities that people have been most impacted by historical, institutional, and systemic barriers. Keris has authored several book chapters and peer-reviewed journal articles on digital technology in mental health, peer workforce, race equity issues, and is the host of the podcast, Unapologetically Black Unicorns. Great title. Welcome.
Thank you. Thank you for asking me. And maybe I should start with a couple of things. So first of all, how I do my work is very inquiry-based. I'm super curious, and so I never take anything for face value, and I ask tons of questions, which could be very annoying to people, but it also tries to lift up things that people, will just take for granted. And the way that I actually met Ron and also Bob, so I'll just put the two of you together, but at different time points, is that when I first entered into sort of the mental health peer movement, I didn't know there was one, right? That there was this kind of recovery thing going on. And when I entered into it, I didn't see anybody who looked like me up on stage talking, leading workshops. A lot of us were sitting in the audience. I'm talking about, in case folks can't see me or don't kind of know what I look like, I am a Black Indigenous person. So there weren't people who were up on stage talking about their recovery stories or leading workshops about the work that they were doing. And I read an article that Dr. Bassman wrote that was about the next wave of the consumer survivor ex-patient movement, which was around youth and communities of color. So I reached out to him and I said, really, because I've given up. I don't believe recovery is for people who look like me, because I don't see them up on stage. I don't see them living out and talking about their recovery. Can you help me find someone I could talk to? And he graciously remembered when we were together in Los Angeles to introduce me to Miss Jackie McKinney. And so that was sort of the beginning of the end for me, meaning that's kind of what got me all involved. And then with Bob, something very, very similar. I think, Bob, you were doing some work around open dialogue. And I said, yeah, great open dialogue. Like, what country is that from? And how many brown people do they have there? Like 0. So I really wanted to know if we translated something like open dialogue to the United States, how would that work in communities of color? Because the last thing I would want is somebody not doing well, not having the supports, a Black man out in the middle of the street, he's a dead man. So I did not see the value of talking about open dialogue without understanding how it works in communities that look, like they do in the United States. So that's sort of always where I'm sort of keeping my eyes open and looking for that representation. So one of the things that has happened to get me more involved in 988, I was already doing work in a lot of different national and federal spaces. And somebody came to me and asked about, and it was a Black group who said, hey, we're looking at cahoots and we're really excited about it. And I was like, oh, I've heard of cahoots. Let me check this out. And they wanted to know what I thought. So the first thing I said is, where's Eugene, Oregon? And when I looked up Eugene, Oregon, I found that it had something like a 95% white population. So I was like, and help me understand how this works for Black people. That is always where I start, because if it doesn't work for Black and brown people, it doesn't work. And I always try to disaggregate any data that's put out there. So like this big data stuff, when people give statistics, means nothing if we don't break it down and understand it by demographics, especially for those who've been historically and systemically and institutionally left out and harmed because we're not looking at those things that are underneath. So when I got involved in 988, because that was and I just said, well, ask. I said, I don't have anything against cahoots, but ask what the data looks like when you're looking at it demographically. So then I was on a 988 call, and many of the groups that were on this FCC meeting we're automatically assuming there was an a priori assumption that geolocation was the best thing since sliced bread. And yes, 988 is going to have it. And I was like, okay, wait, what? Like, no, like back up that train, like put it in reverse, you know, and let's talk about what does it mean when you're talking about geolocation? Have you talked to people with lived experience about what their thoughts are about having geolocation? What level of geolocation? And how is this going to be communicated? So the federal legislation does actually say that geolocation is a part of 988. So it's in the federal bill. And we weren't at the table drafting that federal bill. So the federal bill has left the station and the states then have to figure out how to implement. So, and then also telecom gets in because it's not like Vibrant can do it. Telecom has to do it. And by the way, telecom doesn't want to do it. They're already like, look, we already do it over here for 911, for PSAPs. We don't want to do it for 988. That's going to cost more money, more time. We don't want to do it. That's where the argument really started about to do it or not to do it. About forcing telecom to do some of the stuff that the bill was supposedly requiring. So when that became part of the argument, again, I started saying, again, slow your roll. We have just already had information out, for example, that Crisis Text was collecting data, selling data, using data. So why in the heck are we supposed to trust any of this kuka? Like we can't trust it. So we're gonna have to go with trust here as a start. How can we trust what anybody is doing with our data? Secondarily, in California, in one of our counties in California, most recently, well, in the past, I think it's past year or two, there were 5 crisis responses from the National Suicide Prevention Lifeline when they have to call PSAPs. PSAPs don't always mean police, but for mental health, because it's default at the local level in their regulations, that's how police show up. Primarily. But anyway, they had 5 deaths, 5 killings, and of those 5, 4 of them were Black folk. And it was a very small percentage of that population of that particular county that is African American. So I'm trying to impress upon people that this idea that what we are trying to do is to save lives can also harm lives. And they have to understand the harm story, which is also the death story and disparities for Black and Brown communities. The other thing that I also wanted people to think about, of course, is you know, where is, number one, where is the lived experience involvement to help guide any of this, of what would happen, especially again from communities of color, for immigrant communities of people who do not have documentation, who then could be, you know, really subjugated to all sorts of stuff as far as, you know, maybe being sent back to the country they're from, even though they're trying to find sanctuary here. Like these things have not even come into the conversation, into any of sort of the ideas about how we think about, or how in the legislative policy land, they're thinking about, oh yeah, people call that number. Like, what about those people? Like it's like without the people, it's kind of bizarre. Lastly, I think that I wanted to touch on, oh shoot, what was it? I hate when this happens. So there was a sanctuary for immigrant communities, LGBTQ, communities of color, and the disparities that can happen, including death for those communities in which we're trying to be helped. Oh, right. So for some of the data, going back to what Rob was saying, and there's not an understanding, because even philanthropy is in it, and I do work with large philanthropy to help them understand exactly what happens. The belief is somebody calls the line, they're suicidal, somebody comes to help them and quote unquote save them, and they get their needs met. No, that's not what happens. 80% of the calls can be resolved on the phone. There is no sending anybody. There is no, you know, push out of the system to 911. They're all resolved. So what that tells me is, and again, this is the information that National Suicide Prevention Lifeline collects from all of their centers, their regional centers, is what are people calling about? Yeah, they just want somebody to talk to. They're trying to get connected to resources, all those sorts of things. So what happens to those other 20%? So if it's 80% resolved on the phone, then 20%, there may actually be a mobile crisis center. And when I say mobile crisis, I'm not talking co-responder. Co-responder is generally police and a social worker. And Rob already talked about, and I think Bob too, what can happen there, which is generally involuntary treatment. But in the mobile crisis, it's generally peers. It could be peers, maybe with another licensed professional or something like that. And about 10% or 15% of those are resolved in the field. So you go out, you meet the person, you're able to talk with them, you're able to get the better situated what they want. And then you've got that really smaller percent where they're trying to figure out, should you be calling the emergency communication center or the PSAP, which could be police, EMT, or fire. And that is not understood by people. So even for our public to have a better understanding of what the hell they're like advocating for or not advocating for means they have to have a better understanding of exactly why people are calling, how the lines actually function, and that understand then that small percentage of people in which the PSAPs are called and what is the outcome of that small percentage of people. But most importantly, of course, is, and I think Rob spoke to it, what is the information that is collected? What kind of geolocation and when is it used? Because there are different types of geolocation. And by the way, why isn't somebody just asking at the beginning of the call, where are you located? Where do you want to get your services? Like, let's start there. You don't need the damn geolocation, right? Just start with the question, where are you located and or where would you like to receive services so I can get you to the right call center? And talk with people to find out what they consensually would agree to if indeed they need some kind of quote unquote rescue. Secondarily, let's see. What is the level of geolocation and how should it be shared verbally and in writing? In other words, transparency. Also to ensure that there is a robust stakeholder involvement in the development of anything geolocation related to 988 and not to redefine, which has happened in one state, they redefined what peer meant. So in the money that went to Vibrant that then was for state planning, some of the states redefined peer. And so we're not at the table. Like, what the hell? Yeah, you're going to hear me say a lot of curse words. I hope that's okay. It's a little late now. I've already said them. But, again, I think that is all I really wanted to say, and not to forget too about what's going to be collected related to texting, because it's not always going to be a call that's a verbal call, but there's also going to be texting, which means we're right back at the beginning of what people are able to collect when you're using your device to text. So I'll end it there, and I just want to thank you for allowing me to vent and share this information and sort of my thought processes and what I'm hearing and where I've been involved. So I'm looking forward to the discussion.
Thank you so much, Keris. Thank you, everybody who agreed to present. I'm moved to say a few things that are important to me as facilitator, and then we can go into education. One of the things that has not been mentioned is the culture that's so afraid of death that people who go to a professional are not encouraged to talk about suicidal feelings, especially if they've been through the mill with it. One of the sayings that I've always gravitated towards that I heard from people who were in hospitals when I was working in New York, I may be crazy, but I'm not stupid. And that's the solicitation by people to get things for their records so they could keep people longer or think they've got a good treatment plan. One of the worst things that I think, as I learned to become a psychologist, was the idea of imminent risk. I mean, how do you determine imminent risk? And if you do determine imminent risk, does that mean you have to call the authorities and hospitalize somebody because they wanted to talk about their feelings that they may have thought of suicide? Well, how many of us haven't thought of that? So one other thing I would add to the 988 is I think it's going to flop because it won't be long before people recognize that the cops are coming if they say the wrong thing. So let's open this up to discussion.
People can unmute themselves too. So, or they can raise their hand, and then Susan and I can.
Yeah, if you're not going to speak, please keep yourself on mute so we won't have the background distractions. I see Penny Copeland, you have your hand up, please. Okay. You unmute yourself.
Allow, yeah.
No.
Penny, can you unmute yourself?
Okay, maybe we can get back to you when you're unmuted. You look like you're unmuted now. Sarah, do you or Judine have control over this where you can unmute?
Yeah, let me see. Penny.
In the meantime, Laura, you got your hand up. Laura,
I'm going to ask her to unmute. Okay, now I can see how it works. Okay.
Unmute.
I'm unmuted. Can you hear me?
Yes.
Oh, great. Well, that was really a terrific panel. Thank you for hosting this. Thank you for raising many, many issues, if not obviously being able to answer them. But I'm a recipient of Kahoot services, by the way, and I just want to give a call out to them because they were the most humane service that I'd ever interfaced with in my entire life as someone who's been at times in need of emergency support. So I just want to say that first, but my question really is around, I'm involved with 988 efforts in Washington State, and I just want to hear your reaction to how can 988 interact in any kind of humane way when we have assisted outpatient treatment, which is basically forced involuntary treatment in the community. I don't know how to put my head on that, both of those issues in one breath. I just want to die when I hear about it, but no pun intended. I just can't fathom how we can continue in this field without an implosion of forced treatment. And I just want to get your reactions. That coupled with peers working on emergency teams as well. Thank you.
Thanks, Laura. Are you directing that at any of the presenters?
Actually, any of them that would like to take a stab at it. All three, if possible.
I'll just quickly say, yeah, I don't know, like there's nothing to my knowledge in legislation anywhere relating these two things. Currently, when you're on an AOT of some kind, or even just subject to an ACT team, of course, they can at any time, they usually have a direct line to the police, or they can call 911 to get somebody, incarcerated. So I can't see that would necessarily change. The only thing that, the specter down in the future would be that they're integrating these data systems so that you call 988 and, oh, guess what? They already know you're on an AOT. The moment, that theoretical connection becomes very possible. And then there's a specter around that. But other than that, I can't really think of any way in which they'd necessarily be more intertwined.
Keris, do you want to take a stab at that, or?
Yeah, I mean, I think AOT is always of concern, or using any kind of mechanism to force people into treatment when it's not what they want or how they want it when they want it. So though the two things are not intertwined policy-wise, it doesn't mean that if you, let's say you had a mobile response, the mobile response is the police, you end up in inpatient hospitalization, then that could start the process for AOT, certainly. So I think that's the only connection versus it being an automatic connection, maybe in the minds of the public, especially as different states are advancing the use of courts and saying, oh, it's civil court, so it's okay. What the hell are we doing in court? Like, it doesn't make any sense to get people services. That may be where people might start counting up the number of calls that you've had to 988. Well, you've had 4 calls in the last month, so that makes you more qualified to be in a community-based or to go through a court process to get to be forced into services. As far as peers on mobile teams or peers as part of the process, number one, I do think, and there has been a call out from SAMHSA, there needs to be people who are going to be answering these calls. And I have asked many of the vibrant contractors, if you will, how many trained peers are called. So anyway, what I was going to say is that peers on mobile teams, I think the question for me becomes, are you embedded in a contracted government system, or are you free from that system and there's other funding to support how you do your work? And I think those are things that we have to really look at, especially if you become contracted within a like county system. That may feel a bit co-opting for a peer. It just depends on the space and place.
Bob, do you want to say anything about it? Or?
Well, there's a lot of people with raised hands. I just want to say there's a bit of a philosophical connection between the two. And by between the two, I mean by AOT and when you're sending teams, you're doing the tracing of the calls and sending, whether it be police or a mobile crisis team, to that person's home. Both of those come with the sense that we know better, we meaning society know better, and we can force ourselves what we want on you for social control. And I think Karin said something about the sovereignty of the individual. I think whether it be a 988, whether it be a call line or treatment in the community, it needs to start with the sense that the person knows best, first of all, and you got to honor the sovereignty of the individual. And I'm very always suspicious and leery when society thinks it knows best. And one of the things that Karin was talking about, and we've also heard from Keris and all, there are call lines that don't adopt that principle that you see in AOT, that really are lived experience driven. They don't do any tracing. So I think that's one of the distinctions. And so one of the common philosophies that Laura's talking about is, do you have society knowing best, top down, or do you have something else that is peer driven? And personally, I'm very much against AOT. Doesn't work either. Doesn't produce the societal goals it claims to.
I just real quick, I'll say, I think it just is so clear in the way that the system is built that consent and the sovereignty of the individual is like just built out. And I think Keris was talking about that. It's like, if you really are respecting the sovereignty of an individual, just ask where's your area, right? Or where are you located? And then if they don't want to share it with you, don't share it. But when you're building in a digital, system around seeking that information, obviously without consent, then the whole system is built around that initial assumption that the individual has no sovereignty over themselves, and they also are not the experts on their experience, and they're not empowered to, they don't have the control over their own lives because this other system thinks that they know better. And that's just built into even just the actual technology of geolocating. I mean, very basically and fundamentally.
I would just add one thing, and I would encourage you to look at, if you're interested in the subject of force, an essay written in 1846 by John Stuart Mills on choice. And it delineates where the community may have the right to take over in terms of a person's personal sovereignty. It's an interesting piece that really highlights the issues, and our system of so-called help is based on force, and it's just cannot be sustained if we're going to really help people, no matter what kind of false image it pretends to adhere to. Let's see.
Ron, I'm on the phone with someone who's using the ward, the psychiatric ward phone, and she's under pressure. Can she raise her hand? Okay, I'm raising my hand for you, Don. You got the whatever you call it.
Oh, I can talk.
Yeah. Hopefully people can hear you. Just speak as loud as you can get away with.
Okay. Thank you for letting me raise my hand. My question would be, do you have suggestions for strategies to address this creep of coercion as sort of like the default way that these types of situations are being addressed? So I don't know if the strategy is trying to be persuasive to the decision makers, like the psych docs and the treatment team members. I'm not sure if the strategy is like civil rights litigation, you know, like claims under 42 USC 1983. I'm not sure if the strategy is, I guess, you know, peer contacts or discussions. I found that in my situation, it's been very, very empowering to be able to access information from different organizations like Mind Freedom, IIPDW, Psych Rights, and we sort of formed our own, you know, unofficial, informal psychiatric survivor group here. But I had been in the system for years upon years, and we had never even heard of the term psychiatric survivor. But we are trying to like strategize sort of from within on ways to address the coercion, and I'd appreciate any just ideas, like I said, any of you would have.
Anybody want to respond?
Well, first off, what's the name again?
This was Dawn.
Of the speaker?
Dawn DeZuba.
Yeah.
Hey, Dawn. I'm just really it seems empowering, the empowerment that you were talking about around the psych survivor group that's forming within this institution. That seems hopeful, at least as far as being able to share knowledge between that group that could perhaps grow over time and turn towards actions that could really affect the situation. I don't have any specific, like, as far as litigation or any of those other senses, or even coming up against the force that you're experiencing within the hospital. But I'm just really hopeful for you around that group within the hospital. That's really wonderful. And I'm hoping that the information and knowledge and empowerment that you can share between you there may make changes that could really affect your situation. And so just sending a lot of solidarity.
Just to be clear, Dawn has been in that institution since 2014.
Gotcha.
Thank you for
Gotcha.
Yeah, I'll just follow up from Karin, and that is that I think it takes multiple strategies, not just one strategy. It's kind of like how many different ways can you poke the bear? And so one of the things that I'm looking also in the chat, because there's some stuff happening in California that's really egregious, but one of the strategies that we're using, because it disparately, like grossly disparately impacts Black men, is we've taken a strategy of helping people to recognize that the particular legislation would, again, sort of disparately impact a group of people that never had the access to housing supports, treatment supports voluntarily in the first place. So dragging people into civil court to give them what they should have got as a right at the beginning is problematic. And we have heard legislators struggle with this one. Many of them even though they voted for the bill, sadly, it's still going through its process, but brought this up as, we have concerns about this. This has not been addressed. The other thing that we have to recognize too, and I think we miss this point about who are these legislators, who are the people who are driving some of this legislation, and many of them are elected officials. And we do this thing here in the US, it's called vote. So we can say that we vote, and remind legislators when they're not supporting our interests that we vote. And so, for example, for the Steinberg Institute, that is run by the mayor of Sacramento, Mayor Steinberg, and he has a vested interest in cleaning the streets up, quote unquote, for people who are homeless. So that's how we have to understand what is really the motive and the agenda behind the legislation. So again, sort of how are you going to poke that bear is kind of understanding what is the motive. At least that's how I think of it, among other things, is how are we going to poke or get underneath that bear, or go around the bear and say, great, you have your legislation. We'll try and see what we can do with people understanding that this is what's going to happen and who's going to vote for you. And then secondarily, having our allies and I think Laura Van Tosh does a great job with this, having our allies in legislation to draft our own legislation. Why are we waiting for somebody else's legislation? Those are just some of my ideas. Again, not simple. I don't think this stuff is very simple, but think there are multiple tactics to apply.
And I would just add to that, because for sure I'm agreeing with everything that's been said before, but I would also add, like, one of the key things, like, we need multiple types of strategy, more political organizing across the board everywhere around these issues. But boy, a big thing I'm really thinking about a lot, because I've just been working on a book about the topic of forced treatment and psychiatric detentions, is holy cow, we have no idea even how many people this is happening to, really. The best data we got was cobbled together by a PhD student and David Cohen down at UCLA, and that's like the first group in a long time to even try to get that data. Government agencies that I was talking to, they didn't even want to respond, let alone hand over data, and they weren't collecting it in the end, but they didn't even want to admit that on the record. It took me months to get the Center for Medicare and Medicaid just to say on the record, we're not collecting that data, So what's going on there? I'd say it looks to me like there's a real demonstrable political effort to hide from us all who this is happening to, how many people it's happening to, how often it's happening, what the outcomes are. Like, people aren't studying it and they're not collecting that data, and we really need that. And we got to start putting more pressure on our governments and on these institutions and on the professionals that work at these institutions to say, come on, at the very least, be transparent. If what you're doing is so good and so effective, let's see some evidence, So that's what I want to see.
Anybody else want to contribute to this topic? Kenneth, you got your hand up.
Yeah, to answer Dawn's question, you may be able to use an existing law and argue that your hospital is not in full compliance of it. And that would be Missouri Law 630.115, Clause 1, Subdivision 2, which states that to the extent the facilities, equipment, personnel are available to medical care and treatment in accordance with the highest standards accepted in medical practice. You consider the group therapy that's being offered at the hospital. And a lot of patients at the hospital don't want to attend the group therapy. Why? Because if they attend the group therapy, what they say can be used against them in two ways. The first way is it can be used to keep them in longer. And the second way is it could be used to increase their dosage of drugs. So they can have the therapy, but they can have the therapy with the threat of retaliation. And I don't consider that treatment in accordance with the highest standards accepted in medical practice. So we could start a project to review that and pursue that.
Ron, there's other people that have their question, hands up.
Yeah, I was just wondering, is Dawn still on, Sarah?
She is. Yes.
Dawn, do you want to say anything about what people have said, or?
I just want to say thank you for this. I'll definitely look into them. And I just want to say how appreciative I am that the organization allows somebody like me lots for it's difficult for years to get access to any accurate information, and I'm very, very grateful for your ideas and very grateful for this opportunity to ask a question.
Thanks, Dawn.
You're here. Thanks, Dawn, for coming.
Dawn, do you want our help with this?
What?
Do you want our help for advocating for your rights under Missouri Law 630.115, Clause 1, Subdivision 2?
Dawn, that question was for you. Sorry.
Oh, I just wrote that down, so I'm going to try to look that up.
Thanks, Kenneth. Dawn's writing it down, and she's going to look it up.
Okay.
Celia, you want to weigh in?
Yes, I'm very excited about the panel. Keris, I did a last minute sending it around that you were going to be on the call on social media. A couple of things. In terms of peer specialists or peers, I happen to believe in them because I'm a peer specialist myself, even though I'm not doing the work. And every day I have conversations with different peers about what they can do to help their fellow peers get out of the hospital into the community. Because the system or their supervisors are not really, they're very clinical and then not seeing the person as a human being that can recover. So we have brothers and sisters who are still in the hospital, they're still there. Mind Freedom takes a lot of the calls. And I just feel dedicated to them to say, hey, you don't have to coerce people. You don't have to ask them, what is it that they want to do? And why do we always have to do something? I was talking to a peer specialist, and on his way to work, he visits a homeless person who was in our New York subway and just has a chat with him, brings him coffee and a donut, and says, would you like some? He asked him, would you like some help? And he said, no. And he says, okay, well, let me know. And that was it. It wasn't like, oh my God, you're at risk. I got to, call the police. It's like, that's what you want? Okay. Because he trusts the person knows inherently what they want to do. And that's what I think is a good thing. I guess the question I have for all of you is, the data I think is really important, but I'm wondering how we get outside of our mental health community into the community of our neighbors, our families, our synagogues, our churches. How do we get to them to help us fight, forced treatment and to create new legislation? How do we do that, you think?
That's a tough question you're asking, Celia.
I know. I'm always talking about this, but I don't know how to do it. I mean, I talk to my family members. I talk to friends and, in conversation. Sometimes it's done through training and other stuff, but I mainly have conversations about mental health and what they can do. Because they come to me like, what should I do? Where should I go? And I better have the right services to tell them to go to, right?
Tell you a little story about dealing with that. I was teaching a course in graduate school on community mental health, and I taught the course being open about my background and being diagnosed as schizophrenia. There's probably about 10 15 years ago, and not many people were doing that. One of the students said, "Can I tell you a story?" And I said, "Sure." And she said, "I live next door to somebody who I think she's schizophrenic, and I've avoided going out in the backyard and hanging my clothes on the line when she's out. And after listening to you, I said, well, let me go out and see." And she said, "We've become good friends." And I think it's that way. That was with the ADA and people with disabilities. When I'm old now, and when I went to school, you didn't see people in wheelchairs in the classroom or special classes. And until people are out there and related to as people, I think that's our best bet. That, you know, the segregation, the fears, the not getting to know very interesting people that struggle, I think that's a big part of it.
I just want to like hallelujah that, I guess I would say. I think it's and especially the role that art and writing and for as much as telling stories or any way that you can tell stories, your story, I do find that to be in my life. I've seen the impact that things like different social movements over time, the way that they integrate artwork and storytelling into building solidarity with others and knowing the humanness of each of us. And I feel like art plays a huge role in that in my experience. So that's just wanted to tack that on.
I know I'm talking too much, but I got to share something. Sarah and I were just on a call with two researchers from Portugal, and they're doing a history of the movement. They got funded by the Portuguese government, and they want our archives at Mind Freedom. They're going to help us digitalize it. And we are one of two organizations that were picked out to document the oral histories. And I'm excited about that. I think it's a good thing.
That's exciting. Wow.
Yeah, I think, you know, Ron, you're giving such a great example of how the contact model works. And somebody put Patrick Horgan in the chat box as an example of when people have those positive interactions with, you know, folks who've been given, you know, quote unquote mental health diagnoses. Generally, it starts to break down their misunderstanding, prejudice, discrimination, generalization. So we've done the same thing in the building I live. We have a homeowners association. I live, you know, on the land of the Tongva and Chumash people, which is known as Hollywood, California. And we have a lot of homelessness or unhoused folks. And of course, my neighbors wanted to know what to do. And so, you know, I taught them skills of, you know, greeting people, seeing people as our neighbors, giving them socks, you know, things like that, just, you know, having socks and kind of other things available. So when they leave the house and if they see someone, they can actually start to strike up a conversation and get to know that person as a person, not as a person with a mental health issue. But the other thing that happened too, I think, again, sort of giving California as an example, to Celia's point, is when we tried to build a larger coalition and bring in grassroots community organizers from the Black community, literally people lost their minds. I don't know what happened. And yes, I'm using that term. They really kind of went like, I don't know what happened, but somehow there became this separation between the Black community and the peer community, as if somehow one couldn't be both. There wasn't this kind of coming together to fight the evildoers. It became, well, we're going to go over here because we can't speak on behalf of Black people. And I mean, that was the most disheartening thing for me ever, because I think we struggle with exactly what Celia was saying, is how do we build coalitions with others who may or may not look like us, who may or may not kind of understand our issues through that lived experience walking in our shoes, but are clearly concerned about things like coercion, use of courts, disparities. So, you know, I think there are lots of ways to do it, especially when groups are ready to partner up with sort of non-traditional partners. And by the way, we're working our way through that, just so you know. It started off kind of ugly, but I think we're working our way through that here in California.
Athena, you got to turn yourself off of mute.
Hey, Ron, also go back to Penny, I think maybe. She, the very first person we were to hear from.
Oh, yeah, yeah. Hang on, Athena, we'll get back to you. Penny, you've had your hand up for a long time. I'm sorry.
Can you hear me now?
Yes.
Oh, yay. So my background, I have lived experience, and over the last few years, I've done a lot of self-research into various things. And when I hear about the forced, I think Karin mentioned horrifically violent, the forced treatment and all of that. I haven't heard yet about polyvagal theory and how that relates, which ties in with the health of the nervous system. And that to me seems directly related. It's tied in with the fight, flight, and freeze modalities of the nervous system. And I was just wondering if any of you had heard of, the impact of this forced treatment as it relates to the nervous system and that type of thing.
I might be able to speak a small bit about that as far as my involvement in the withdrawal community, the psych med withdrawal community. I gained this sort of wisdom over time from several different places around the withdrawal being very centered around different strategies of calming the nervous system, because it really does sort of, I find it to be a root of a lot of these withdrawal symptoms, as well as trauma symptoms and everything else. So then they sort of make a pretty rough web of a tough time sometimes. But so I just wanted to mention that the idea of this soothing of the nervous system is definitely something that I've learned in my experience as a person withdrawing from medication and a person who's experienced psychiatric trauma and a psychiatric survivor. So it is in the conversation, and I think there are many different ways that people talk about it, including the polyvagal theories and other things, down to like coping mechanisms like sense and different things that people are using to help with dissociation and other things that may or may have not happened to you as a survivor. So I just wanted to mention that.
Well, and I should have mentioned just earlier this week, I finished reading Robert Whittaker's Mad in America, and the whole Quaker treatment that ties directly in with polyvagal and why it was so successful, I believe. And so I just thought it might be something to add in to some of this discussion, as it relates to the nervous system. So I wanted to bring that up as an idea.
It'd be interesting to see if there's any research. It would probably be very difficult to isolate the variables to do that, but I don't know of any. Do you know of any, Bob?
Well, you know what? This is really a good point, I think. In a way, you can see it in the ACE study, and the childhood adverse childhood experience study, and children who aren't safe and are on high alert all the time. That gets built into their nervous system, and it's long lasting. And I'm pretty sure that forced treatment has the same thing of sort of not feeling safe, putting you on high alert all the time, and those things. In what the ACE study shows us is that they really change you in a physiological way. And one of the things I think we see from the ACE study, and also one of the things you see, when I wrote this book, Anatomy of an Epidemic, I went to this place outside of Oakland where they worked with, quote, the worst kids. By that means the kids that were seen as the most disturbed. Well, one of the things the psychiatrist there, who was really a great guy, said the very first thing you have to do is build where they feel safe. And they can be safe with others, with these kids, because they haven't found their place to be safe. Anyway, I think clearly that if you're constantly on guard and you don't have safety and you don't have a social net around you, that does something to your nervous system that's not good. So I think maybe we don't know the exact thing, but the ACE study, that's so much of what it's about how early childhood trauma and lack of safety, lack of physical security has a long-lasting impact on human beings.
I guess I was thinking this relationship to the nervous system as it associates with forced treatment.
Yeah, and I think obviously puts you on high alert, right?
Yeah,
you have people coming and
some study or something. Yeah,
I haven't seen a study specifically regard to that, but just in terms of common sense, think about it.
So in my research, I found that forced treatment is just generally desperately understudied, and it's widely recognized. Like if you start to find some of the reports, reviews that have been done, everybody's remarking on this. Like, gosh, it's the most common way of treating people around the world, and nobody's actually studying it in terms of the outcomes. What are the outcomes? Do people get better? Do they get worse? So there's no science there. So that's the problem. But as Bob said, I think that you're absolutely onto something with that question, right? And there probably are things that are really happening, and probably very damaging things. Especially the more somebody resists, right? The fight plays out and the intensity increases. What's going on there?
Okay.
Yeah, even when we just look at the language that we hear people use to describe forced treatment in or out of the psych survivor community, it's the language itself is reflective of damage and injury and violence. So it's just, as an anecdotal point of data, as far as storytelling, just the language we use could tell us a lot about what it is to the nervous system.
I'd just like to respond to something you said, Bob, about the ACEs study. One of the things that I'm most impressed with by the people who show up here, or all the people that I've met down through the years, is the ability and the resilience to recover. And about 15, 20 years ago, when I was doing some research on my book, I found a study that was done by 2 psychologists out in Hawaii, where they did longitudinal studies of the worst treated kids who were most abused. And they looked at it, and there was a certain percentage of them, I forget the number, who were completely recovered. They led a very good life, and they tried to isolate some of the variables. And one of the variables that kept coming up is if they had a mentor, a sports coach, or somebody that related to them. So, I just think as human beings, we have so much of a capacity to recover if we're not set off course by this stupid mental health system that doesn't work and forces people to get things that they don't choose. So that's my spiel. Let's see. Yulia, you wanted to say something? You have your hand up?
Yes, can you hear me?
Yes.
Well, it's just such a wealth of very convincing data that I'm sure I'm not the only one who would find it very useful, for advocacy on like local level. And I just wonder if it's possible to share citations of especially what Bob Whittaker cited, all these extremely convincing numbers and authoritative studies. So if there is any place where one can look for those citations, I think it would be great. And also I have a question. I'm exploring various, roads of activism and advocacy. And recently I gave a public comment at SAMHSA intercommittee meeting on serious mental illness. And I wonder, more experienced people, do you think it can have any impact? And if there is, any sense in recruiting more people doing those public comments and countering the narrative of, well, all those pharma funded organizations, probably they assume that those public comments will have an impact. because clearly they send their people there. So I just wonder if we can try and, compete with them on this front. Yeah, that's all.
Okay, thank you. Does anybody want to respond to? Bob, you look like you were going to say.
I'll just say about the citations. They all come from an article called "Suicide in the Age of Prozac." I'll see if I can put that link in the chat box because they're all linked to the studies there. If not, if I don't manage to do it successfully, just go to Mad in America, put "Suicide in the Age of Prozac," and the article come up, and you can go all to the citations there. Okay, I'm going to see if I can find that now.
Bob, do you remember when we met in Massachusetts and we were talking and I said research doesn't do anything?
I do remember.
I think it does to a certain degree, but I think it's really the power of the people, really convincing people. And I think research convinces professionals, some professionals, or they deny it, and academics. But for the people who have the lived experience, I think we need to gather them up. And that's part of why we do these meetings, because it's cross disability, to create a bigger number of people that can actually exercise power and show that we have some influence. Not saying to stop doing research. It's just.
Well, I'm not doing the research. I'm just recording what has been found.
Yeah, I know.
Real quick thing, Ron. I just think the research actually helps amplify the voice of those with lived experience.
It does.
Because it supports the voice of lived experience is what it does. So
yeah.
I don't want to, sorry, Bob, I don't want to jump in and, my boss's defense, but, I definitely want to defend you a little bit here around the fact that when the science was really what in one way that validated my peer experience as like, oh my God, yes, this was my life and this is in the science and this is out there and this needs to be, so maybe it's a collaboration in a sense, like
of course it is. I was just picking on Bob from way back.
Good.
Yeah. I think Athena, who is one of my favorite researchers, would you, I don't think you're unmuted if you're trying to speak. Where's somebody who is Judine or Sarah here or Susan who can unmute Athena? Can't hear you.
I'm trying.
Oh,
Athena, you need to unmute yourself. I can't do it for you. Okay.
Oh, maybe she can throw it. Oh, her mute's not actually unmuting her.
It might be her speakers.
I hate she's been
I'm
waiting.
sorry, Athena. I really wanted to hear what you have to say. Maybe we can get back to you. And
or you could write your question in chat, Athena, and I'll read it out loud. She's trying to mute it. I can tell. She's trying to unmute herself.
Well, we've got a bunch of others that have been waiting too. So why don't we go to Courtney, who seems to have been waiting the longest.
Hi, can you hear me?
Yes.
Okay, thank you so much for all the presenters. I really appreciate your insights. I'm a psychiatric survivor who's been physically and psychologically harmed by forced treatment. And so I guess one of the things I've been curious about when I've been involved in advocacy and seen some changes in the process is kind of states putting in place certifications for peers. I've had some really invaluable interactions with the peer movement, but I found sometimes professional gatekeeping limits who is allowed to be a peer and who is deemed successful enough at treatment to be a peer. So I guess it's a concern I have, but I'm just wondering about your thoughts.
Can I jump in on that one, if that's okay as a start? I totally agree. And I think that's why I talk a lot about co-opting the peer workforce. And where a lot of the regulations come from to regulate the workforce, especially if you are certified, comes from CMS, the Center for Medicaid and Medicare Services, that has a list of requirements that then the states have to implement. So again, sort of we have sort of government control, kind of figuring out something about a workforce that they don't really know much about. Well, they don't know anything about, let's just be clear. So, and then you have the state that has to interpret what the feds say, sometimes the states are not even clear about what the feds have said. That's why NASHBID on several occasions did letters to state Medicaid directors to clarify some of the ruling by Medicaid. Okay, so that starts it. And then of course, Medicaid says, well, who can supervise? And that's been misinterpreted as it has to be a licensed professional. And that's not what it says. Not what it says at all. It says it has to be a qualified mental health professional that's defined by the state. And then the state can put in a peer as that qualified mental health professional when they're adding in that workforce. So, and that's where you can have a little bit more control over ensuring that the workforce isn't co-opted or starting to do things that look like many clinicians and looks more like what we would think about a peer supportive services. So, I think you're absolutely right that there's like this weird thing happening, especially with certification. But if you are working outside of the system, you can get away with not having that certification. You just have to get your funding from someplace else and not bill Medicaid. So, and then, I think if we could think about how do we build a movement where we can get funding that is not non-governmental funding collectively to support more, I would say, sort of mutual aid, value-based peer work is one way to also move forward. I hope that helps a little bit. Sometimes I don't think people know where the stuff comes from, and somehow they think it's the state that's doing it or it's the DMH that's doing it. Well, no, it's kind of the feds that started it.
I'll put these in here in the oven.
Yeah, I might be able to help.
It seemed like we're cooking dinner with someone. I also wanted to say too that I'm trying to find this article I remember reading on Mad America a couple months ago. It was a personal story from a peer specialist. I'm going to throw my email over to you, and perhaps I can reach out. If I find it during the meeting, I'll post it in the chat. But it was a great article, a personal story from a peer who was talking sort of about this dynamic a bit. So hopefully that's helpful.
Okay. Penny,
I think Athena got her mute function working, I think. So maybe.
Athena, you want to try it again?
One more second. Can you hear me?
Yeah, there's just some background. It's your speaker, I think.
I'm going to try to talk through my phone.
Okay.
It's creating a reverb, so.
Yeah.
It's just not working.
Maybe you could stay on your phone and log off your computer.
Yeah, that's what I'm going to do.
Okay.
Let's see. Laura and then Kenneth.
Yes.
And anybody who hasn't spoken yet will have priority. Laura?
Already spoken. I just accidentally raised my hands.
Okay.
And waved it in the air.
It's always good to hear from you, though.
I guess the one thing that I am troubled by are all the people that are getting committed by AOT orders, assisted outpatient treatment. And, we've got to reach them either, ASAP. And what I'm talking about are really people who are homeless. And Keris knows this because of, care courts in California that's been being debated. We already have that. In fact, I think all we did was put our law on an airplane and fly it to Sacramento because it's virtually identical. And I'm just deeply concerned. We have 40,000 people who are homeless in King County, where I live. It's the third largest homelessness population by county across the nation. They're the targets, and they're disproportionately representative of the BIPOC community. And we've got, you know, I'm looking at one African-American woman, Keris, and 5 white men on this call. And we've got to, you know, up our numbers here and really hear from people. And I fear that we're not hearing from homeless people because there aren't any homeless people on this call. But we're going to need to reach out and rescue these folks. And we've got state hospitals with cold beds. So they're looking forward to filling those beds up all over our state. So I guess I'm like watching a train. Someone brought up the train earlier. You know, a collision course here. And I'm just, I don't want to repeat myself, but I'm worried that we're going back in time. We're going back decades. We're going to be resorting, actually, our unionized hospital workers just staged another kind of pseudo strike on the lawn of one of the state hospitals. That they're low staffed, low paid. So we've got people going to state hospitals where there aren't enough workers working there even. So this is like worse than prison here, folks. So if there are just any reactions, I'd really appreciate it.
Laura, that's exactly the point we're trying to make to people, is that there's no system there. There's no there. So you're actually, quote unquote, adjudicating people to something that doesn't exist. And so you're pushing people out to get people in. So you just have this vicious cycle. And then secondarily, it's a belief that what we have is actually working well for people. So we don't have enough information about what we actually have. Sort of sucks. So we're kind of, adjudicating, if you will, people to sucky things versus things that really help. So the legislation isn't about homeless people, nor is it about mental illness, nor is it about the things we care about. What it's about is the legislators hearing from the public, get those damn crazy homeless people off the street. That's what the legislators are trying to solve, because it is an election year. And I think those are some of the things that we have to wrap our heads around too, because this all came out during election year when people, all the mayors are on top of it. Yep, we want this. Governor's bill, of course he wants it, right? So I think if we can understand what is the public really saying, and I think, and this is just Keris Myrick, really thinks the public was saying, if I see another crazy Black person on my street, I'm really gonna not vote for you, Mr. Mayor. That's what I think is really happening. And so, and again, I know everything doesn't come down to race. I don't mean to make it that simple, but I do think that the public is saying, do something. And this is what they're doing. So it's not really about solving homelessness. Otherwise, there'd be affordable housing. Housing in California is outrageous. And they're not building any housing. They're not putting any housing funding. They're not building more, they're not adding more workforce. So how are they going to serve suddenly all of these people with no there? And I think that's what we have to help people see, is there's no there. It's, I call it a kangaroo court. Yeah, I'm getting kind of wicked.
Ron, I think Cheryl has almost given up on getting her answer. And also we're going to do another Judy's room on homelessness. So keep posted,
Yeah. Okay, Cheryl, you had your hand up. You're on mute.
Can you hear me now?
Yes.
Okay, so since I've been waiting, there's more things coming to mind, so I'll try to be brief. I am a certified peer. I'm also a psychiatric survivor. I also live in a state that has what they call Kevin's Law. So they are people are court ordered if they refuse to take medication, and it's a matter of heart at me. And I also work in community mental health, but I'm in this catch-20 situation because I have to be like, mom's the word. You know, I have this job. And so I want to go to my original statement was, you know, the White House or the press release, or was it the State of the Union address, is advocating for more peer support. And then we don't hear much from it again. And then I see this press release I got yesterday. I'm just gonna read you this sentence from the small portion of it. Establish a federal research action plan on mental health. The underlying causes of most mental health conditions remain largely unknown, yada, yada, how they're gonna address it. And it makes me so angry because the causes of mental health are known. It's usually trauma background. I'm a huge Governmate follower, and I know that's where my problems came from. And I'm just, I want to take some people and choke them. You know, they just don't see that. They don't see what we see. I don't understand why they're not listening to us. In one aspect, they want to focus on peer support, and now we're not hearing anything about it. And I just don't understand why people are so blind to what is really wrong, or are they pretending so they can keep making money from pharma? I don't get it. I don't know.
Cheryl, I love your
I can go on and on.
No, Cheryl, please, if you want to, go for it. I wanted to tack on another rant at the end of that because I'm feeling the same stuff.
I'm really angry right now because I need my job. I work in community mental health. I don't work at the end where there's prescribing going on anymore. I do public educating now, so I close a blind eye to what's going on so I can have a job. And now we got infant mental health. We have an infant mental health unit now in our agency. We have CITs that use social workers and not peers. And I just feel like it's going nowhere. And I'm in a situation now that I want to work. I'm at a crossroads in my life where I want to leave what I'm doing because I can't advocate properly the way I want to. I don't really know what else to say. I mean, you know, and to work in a state that has a law that forces people, and I see the stretchers coming in and they you know, get taken to the hospital. I just, and I hear the social workers in the bullpen, you got to take your medication, you got to take, and I have to just close my eyes to it because I can't get them to see what I know or to know what I've experienced. You know, the withdrawal from benzodiazepines, and you know, and the film is coming out. I'm seeing it this weekend as prescribed. I'm excited that I'm going to finally get validated too.
Thanks, Cheryl. There's no answer to your question, but it's people like you and others that will help change the system. I have to be optimistic about that. I hope we see it in our lifetimes.
Well, there's a group of peers in our state of Michigan that have talked about reversing the Kevin's law. Like we're up against a huge, I mean, the money-making county that got it enacted. We'd be fighting. We're going to be fighting a big fight if we try to get it turned around, because I just don't believe in it. And any clues or hints or something that we can do to try to reverse this law in our state would be tremendous help.
Celia, do you know what the situation is in New York when they tried to renew Kendra's law, where that is now?
Yeah, they did renew it for, I think 5 more years. And what they put in, I have to remember, they put in a provision that we didn't like, that when they serve their time on AOT, Kendra's law, but they can get off, but if they're not doing well in their terms, they can get put back on. Something like that. So it's not great, but they didn't make it permanent. They just keep extending it,
It's a tough fight, Cheryl. We fought against that really strongly and lost. And force is the battle. Whether we can change the way services, they're not really services, they're controls that are put on people. One of the things I testified for the United Nations, which is doing a deinstitutionalization program, they allowed, it was from Canada, United States, and the Caribbean. And they were doing it in different segments all over the world for deinstitutionalization. And one of the things I said is, I have no research to back this up, unfortunately, but perhaps 90% of the people who are forced into treatment don't need to be forced. They don't need to be contained. Maybe 5% of the people, because of the threat to the community, need to be contained, but we treat everybody as if they all need to be contained. I'd really like to hear what you have to say, Athena. I don't know if
Can you hear me now? Are you able to hear me now?
Is that Athena?
Yes, it is.
Yeah, I hear you.
I can't see anybody, but at least you can hear me. I have a very cynically optimistic comment to make, and it's very general. And it is that, when I first got into researching psychiatry and the movements, I was just appalled at the forced treatment, the lack of transparency, the lack of informed consent. And then when I started studying dementia, I saw the same thing. And I concluded it had something to do with the Western emphasis on rationality and personhood and the terror people have at supposed cognitive impairment and madness. But having seen COVID, I think it's a broader institutional, tyrannical, medical, systemic control thing that's going on that goes beyond mental illness as perceived, cognitive impairment as perceived. People were forced into hospitals under protocols they refused. They had medical directives that were ignored. They were forced to take medications that were given subsidies by CMS if the hospitals followed them. And people repeatedly experienced treatments which, very much like suicide interventions, led to more suicide, treatments that led to more deaths. And Big Pharma had its, dirty little nose in this whole thing, controlling it along with the system. But the positive thing of this horror and all the deaths that I think have resulted from bad interventions, the lack of alternative treatments being allowed, medical institutions refusing it. The good thing is that so many people have been affected by tyranny that their feelers are up and they're now questioning the system. And I think will be more receptive to the experiences of people who've been forcibly treated for psychiatric reasons. So that's just a general comment.
Athena just is an anthropologist. I don't remember if you're a medical anthropologist, but you did some of the best work that I've seen on NAMI and their influence on treatments down through the years, how it arose and what it's done.
Katie.
What you're talking about reminds me of a pattern I'm seeing emerge with Roe versus Wade possibly being overturned. We're going to have this huge body of children that are adoptable. But what's happening already is an awful lot of young parents are being forced into psychiatric care and forced to give up their kids. And now we're going to have a larger pool of kids. And we already had a Supreme Court justice say, we don't have enough white kids to adopt. And so I can see down the line that pregnant women who are going to be at high risk of forced psychiatric treatment in order to get their babies.
A dire outlook.
Recording.
Let's see, anybody who hasn't had a chance to speak?
Yeah, Ron, can you hear me? It's Bonnie, host from New York. Can you hear me?
Yes, I can hear you, Bonnie.
Okay, for some reason, my Zoom won't let me, it doesn't have the hand icon, so I was trying to find it, but couldn't. I wrote a lot in the chat. I hope you can see it. Could you see any of the comments that I wrote? Okay, good. Someone was asking it about strategy and 3 ideas. 1 is class actions, 2 is multi-jurisdictional litigation. And then another thing that happened in the last 2 weeks to me, because I've been over the last year writing to different people because I was talking to people that I should have been able to trust, but obviously couldn't. So I broadened my audience and started writing to the police commissioner in New York. One of her
Bonnie, do you have a question? Because there were people in front of you waiting to speak.
Oh, yeah. Well, I guess the question is, what efforts has this group made in terms of class actions and multi-jurisdictional litigation? And then the last category, which I'm cautiously optimistic about, is the civilian complaint boards of the police departments. I'm not a criminal law lawyer, and I've had a really, really awful time with the 19th precinct in New York. But I did get a call from the NYP, the civilian complaint. It's run by civilians. It's not run by police officers. From the Civilian Complaint Board, and in New York City, at least, the Civilian Complaint Board does have jurisdiction or purview over sort of unnecessary force. And it was the first time it sort of like got into my head, and I thought, well, this is unnecessary force. And I spoke to the woman who called me, and we're going to talk about at least the last 2 times this has happened to me. So civilian complaint boards might be a little bit more open to listening to what we're saying, But I was just wondering if anybody else had experience in those 3 in terms of strategy.
No, I'm sorry, this is Sylvia, but I think it's a good idea. I'm gonna look into it. I'm from New York, and I'll look into that. Thank you for bringing that up.
Sure. Sorry, what did you say your name was?
Celia Brown.
Thank you.
Let's see, Carolyn Green, and Bronwyn, you could be next.
Ron, I think, were they first?
Who? I don't know. I don't know who was first.
Well, okay.
In order.
Yeah, I think there's an order, and Cindy was next, and then Bronwyn after that.
Hey, just real quick, I have to jump out. I'm so sorry. It's been really wonderful spending time here with this discussion. I'm glad to have been a part of it. So thank you. But I have to get going.
Can I just ask a quick question? Did I thought this was going to be at 6 o'clock. I want to know that I'm in the right meeting here. What was the title of it, and was it at 6 o'clock, or am I hopping on?
What time zone are you in?
I'm Mountain time zone, Mountain Standard Time.
No, it's a Mountain Time. It started at 4 o'clock, and it was running from 4 to 6. But I'm sure there'll be people who will stay on if you like. And let me shift. I think Sarah said that you were next, Cindy.
Okay, can you hear me?
Yes.
So I guess I just want to point out that, and I think illegal fights are good because at least they expose to a wider group of people what is needed and what is wrong. But I also, I've kind of given up on that legal thing, and I'll give you 2 examples. Is like when Bush did the Freedom Report in 2000, and Dan Fisher helped write it, and he brought in all kinds of information from survivors and the movement. And what actually survived the most in that was TMAP. And I'm assuming most of you know TMAP is where there was this prescription that if someone was diagnosed, in order to get insurance, the doctors had to prescribe, first of all, the most expensive, which was Risperdal for schizophrenia. If that didn't work, then add another drug, and then add another drug. And eventually it shifted and changed. And eventually there was millions of dollars of lawsuits that ended up, states ended up suing because they ended up going bankrupt because Medicare was having to pay all that. But again, it was a game because my son was one of those folks that got Risperdal before it was even FDA approved. And I have all the records, and our state got $22 million. So I called the Attorney General and I said, I have proof that my son was given an experimental drug, the maximum dose as a minor, the maximum adult dose, and that he became not homicidal, but suicidal, self-mutilating. And this was all documented. And I'm in the state of Washington, and the governor at that time said, oh, I'm sorry, but we're giving half of that 22 million to Medicaid investigators to prevent fraud. And I have yet to hear of a doctor that's been charged for writing a non-FDA approved drug. And then the second part was going to go to pay the state's portion of the Medicaid bills that would result from the harm of the drugs. So in many ways, we're just a pawn in a game, I believe, where money transfers at the top. So I'm at the point now, I've chosen to live without a home. I lost it because I was trying to keep my son incognito in an apartment complex that he shouldn't have been, and he needs a lot more support. And they, I think, in some ways, rightfully said, you can choose to vacate or he's going to get trespassed. But my goal, I felt like people in housing and in the comforts and still believing in the American dream are too comfortable to make changes. I'm finding more and more connections on the street to build the alternative without the system. Now, it's not people with money yet, but I think the more that we gather people who have been dispossessed from the idea of the American dream, the more that brilliance is going to come together to create the alternative. So in some ways, I think as horrible as the last 2 years have been for people, as someone else said, they've waken up a lot of people who lost their jobs, their loved ones, and they realize in many ways the corruptness of those who control our lives.
Thank you, Cindy. Yeah. Bronwyn, if you turn off your mute.
Hello, how's everybody? Thank you for putting this together. I got a couple of comments and a huge question, maybe a couple of huge questions. My first couple of comments is, first of all, right now I'm serving as the president of the National Coalition for Mental Health Recovery. I am also a certified peer support, and I also just recently started my own business because of everything we just talked about around co-opting peers in the workforce. And I'm a strong believer of not co-opting peers. I was a supervisor of a peer team at a local CMH in Portland for some years, and I got pushed out because of that interpretation that it needed to be a licensed social work, but that's okay. I also, as a representative for the National Coalition, sat on the 988 implementation team. And it was a fight. It was not, I mean, it felt like a fight because myself, Dan Fisher, and another colleague, we were the only peers at the table. And it's hard to have your voices heard when you're the only peers at the table. Laura made a comment earlier about, about all the presenters here being of a Caucasian descent. And part of that reason is two reasons. For one, we're usually not asked to be at the table. And two, when we're asked to be at the table, no one listens to us. Our voices are not heard. There's a difference between equity and equality, okay? You can include me and I can have an equal seat at the table, but that don't make me equal if you're not hearing my voice. And that's what I came against when I was sitting on that SAMHSA team. I was the only Black woman with a mental health experience, lived experience. And it was hard to be heard. Very hard to be heard. The next piece I wanted to bring up is everyone here, I heard Bonnie talking about this class action suits, this, that, and the other. I am full-fledged wannabe advocate. I am full-fledged believing in writing and protesting our leaders. My question is, how many different organizations, peer-run organizations or disability organizations are in this room right now? I counted when I came in here, 96 people. If we all got together as one and put together some legislation and just keep going at it. We can't just do it once and just fall back. I heard Cindy mention a few minutes ago about Dr. Dan Fisher helped put together something and it'll go so far. If they can keep spinning us around, it will fall off. But if we keep drilling, there's power in numbers, there's power in repetition. We were taught over and over again, the squeaky wheel is going to get the oil. We have to just keep advocating, but we have to do it together.
So how do I wait to speak is what?
I'm sorry. Oh. I'm not controlling this. I'm just putting out my thoughts, my feelings, my voice, and just sharing why we're not at the table and why we're not pushing. That's my question. Why are we not coming together and unifying all these organizations? You got 10 or 12 organizations here that can put together a series of letters and just keep bombarding Washington, keep bombarding the court systems, but we do it together, not as individuals. That's just my thought. That's just my opinion. Thank you, I'm through.
It's a good opinion and a good thought. That's why there are different organizations here at Judy's room. That's what we're trying to do, and I think you're absolutely right.
I'm sorry. I just heard about Judy's room today. I heard it from Cheryl. And I didn't hear about it from anybody else. So if I'm just not hearing about it, as the president of the National Coalition, how many other people are not hearing about it?
Well, it went out, Audwin and Cecilia. How you doing? I put it on social media on our Surviving Race page.
I saw that. I
don't know if you're on the mailing list for the Mind Freedom Judy's Room. You might want to talk to Sarah to get your name on, because it did go out.
I'm there, but I work a lot. So sometimes somebody just have to pick up the phone and call me.
Bronwyn, can I call you? I'm going to do that. I'm going to get your contact information on our list.
Yes, just call me.
Thank you.
I work too much. I'm trying to start a business, and that takes a lot of work.
Well, glad that you did find us. Let's see. Sarah, you seem to be keeping better track than I am. Who's next? So
well, before you ask someone, could you just kind of give the presenters like a heads up that they're free to leave, because they've been working really hard, and Judy's room stays open for another hour for people who want to stay, and the presenters are welcome to stay, but I don't feel like they should feel obligated to stay.
I think you've announced it.
You're off the hook.
Okay.
Cindy, I think Cindy's gone, so Carolyn and Adrian Stacy would be next, and after that, Jeff and Elisa Clay.